I want to start out with a brief introduction, and that is to say that this presentation is on smooth muscle tumors of uncertain malignant potential and was done with collaboration with Dr. Michael Makii of Texas Tech OBGYN. Stump tumors themselves are a rare pathologic variant that continue to cause arguments among those in the academic community, and their rarity exists because it's often hard to clinically define what these tumors are between a more benign leiomyoma to a more serious sarcoma, though often they can have features of both. Genetic studies, however, have shown that they are in fact a genetically distinct variant and are not themselves just a continuum between the two forms. However, clinically this is hard to appreciate as there is no defining features which signify that they are a stump tumor. In fact, one source cites that a leiomyosarcoma must include two of the following: diffuse moderate to severe atypia, mitotic count of at least 10 mitotic figures per high-power field, and significant cellular atypia. This same source then goes on to say that stump tumors are those tumors which do not quite meet this criteria. Thus, stump tumors can have a wide range of appearances, having different cellular atypia, mitotic activity, and necrotic appearance. However, what is agreed upon is that a particular variant with geographic appearance where there is strict definitions between necrotic tumor and viable tumor tissue is more likely to be serious in nature. The risk of adverse outcome with these tumors ranges from 5 to 30%, with some causing local metastasis and more serious cancers, including leiomyosarcoma. Further complicating this is that there's no definitive way of imaging these tumors to differentiate them, and they often present in the same way as a leiomyoma or a leiomyosarcoma, with uterine mass, abnormal uterine bleeding, and pelvic pain or pressure. The only way that these tumors can be truly defined is by hysterectomy or myomectomy and the resulting pathology. This case is built upon the presentation of a 45-year-old woman who was a gravida 2 para 2 who presented with a suburethral mass that was in the area of her introitus, causing her issues with pelvic pain, dyspareunia, as well as urinary incontinence. Additionally, when we examined the tissue area, we thought it was a urethral diverticulum due to the appearance, or rather loss of urine every time we tried to push on it. But the mass itself was somewhat difficult to explore because it caused her a lot of pain every time we tried to palpate the region. This led us to take this patient back for surgical procedure, in which case we were going to try to excise the mass, which was approximately golf ball sized. In the surgical field, it quickly became apparent that we were not dealing with a urethral diverticulum, as what we encountered was a spongy-like mass in the same area, but hard to define in its boundaries and also hard to dissect. The largest piece of this tumor that we were able to resect was 5 by 3 by 3 centimeters. We also were able to get out a smaller 1 centimeter piece, but there may have been some tissue left behind. Initial frozen section on the tumor showed it to be somewhat concerning in nature, as they were seeing mitotic figures, but would not be able to further give us any further information without doing more extensive staining. The area of the tumor is then marked with surgical clips and closed in an overlapping fashion, and a Foley placed to allow for better healing and drainage of urine in the next 2 weeks prior to having the Foley taken out. Final pathology from our hospital showed features of stump tumor with increased mitotic index. However, the tissue was otherwise pretty benign and showed no presence of necrotic features. Our pathology team, however, wanted to consult the Mayo Clinic as they were unsure of the diagnosis, partially due to the mitotic figures and otherwise benign appearance, but also the location of the tumor itself. After some time, the final results from the Mayo Clinic came back for concerns for stump tumor due to the mitotic figures that we had seen, as well as the presence of the tumor in an extrauterine location, with most of these tumors arising in the uterus itself. The WHO classification system of stump tumors includes those tumors which cannot be classified as either histologically benign or malignant. And if you had made the same mistake as I did initially and looked at the Stanford criteria by Bell and colleagues, you may have assumed that stump tumors do not exist outside of the uterus itself. However, this is not the case. They are just very rare. Our case is not unique either, as periurethral stump tumors have been found previously in Connecticut, and other stump tumors have been found in such areas as the broad ligament, but case reports are limited. Controversy will remain as long as difficulty remains in defining the characteristics of this tumor both pathologically and clinically, including what features are required in order to make the diagnosis. Complicating the issue of diagnosis is also what to do with these tumors, as although most of them remain benign, as many as 20% of them can be potentially malignant. The diagnosis of stump tumor is not one to be taken lightly, and great care was taken in our case as well to make sure that the diagnosis of stump tumor was correct in our patient. Currently, our patient is doing well and is currently scheduled to receive follow-up care every 6 months for reevaluation of her tumor. Factors that will be addressed with this patient include whether or not her symptoms represent or she has any continued growth in this area, as well as local metastasis. This case is also interesting from our standpoint, as this is the third stump tumor that we have seen in the last year. It'll be interesting to see if there are factors associated with this area that makes the prevalence more common.